We finally found our clinical case, so we can do it. For the expert, it's a 9-year-old boy, a ski competitor, and he sustained a primary ACL rupture 6 months ago. He complains of instability, lack mass soft endpoint, explosive pivot shift. I don't have the MRI, but he had ACL rupture and a medial meniscal lesion. So, what's your first option when you see those patients primarily? Loïc, what you do? You try a non-surgical treatment first, you go straight to surgery?
Pour moi, s'il est instable et on est à 6 mois, je l'opère en première indication, en première intention, effectivement.
What kind of graft do you use for primary?
Pour ma part, je fais systématiquement un DIDT, un 3+2, avec une plastie antérolatérale ODI, un tunnel fémoral qui est épiphysaire, et une fixation vis-vis.
Bertrand, you do Macintosh for this kind of patients?
Yes, I do Macintosh for all the kids. For one of the main reasons is for me is unfortunately the next candidate for revision. So I want to leave in place the hamstring and other option. So I use the IT band over the top.
Okay. So in this case, he had the ACL reconstruction, isolated ACL reconstruction with the technique of Franck, with a quad tendon and a medial meniscal repair. So how do you manage your post-op period, Charles? Qu'est-ce que tu fais? Est-ce que tu les brides?
Alors oui, ça c'est.
Tu les immobilises en post-opératoire?
J'ai tendance à, vu qu'il y a une lésion méniscale, pour toutes mes lésions méniscales, je leur demande une dizaine, quinzaine de jours de porter une attelle articulée, ne serait-ce que leur faire comprendre que c'est pas un genou tout à fait comme les autres. Ils le comprennent assez rapidement parce qu'ils se sont fait opérer. Appui complet. Et je limite la flexion. Il y a une suture méniscale, hein, donc je limite la flexion à 90 degrés. Et on a quand même un suivi qui est très complet avec 3 semaines médecin du sport, 6 semaines avec moi avec radio, 3 mois avec moi, ensuite 6 mois, 9 mois, 12 mois. Et à chaque fois, l'enfant, on lui redit que qu'il faut pas aller trop vite, que même s'il se sent très très bien, eh bien le ligament n'est toujours pas prêt. Et ça c'est redit très très souvent. Donc oui, on met vraiment le mort dans la bouche et on tire fort.
How do you organize the return to sport, Eduardo? What's the timing? 1 year?
In this case or in general? In general, in pediatric patient, usually for me returns to sport is very, very late respect to adults, so 9 to 12 months. First of all, this is what I say always to the kids and the parents. So in my opinion, return to sport should be late. And just after surgery, first thing is to maintain extension, both with a muscle activation, quadricep activation, and brace in extension. And then in this case, there was a meniscal suture, so maybe restricted range of motion up to 4 weeks, and then standard protocol, but late return to play.
Okay. So 2 years later, he came back. He was 11 years old. New ski accident. New ACL rupture. This is the X-ray. What's your plan, Alan?
Thanks. What is my plan? A challenging problem now. Anterior translation is an issue. His growth plates are still open. He's now in valgus. So this is where I do consult pediatric colleagues who've got bigger, much more experience than me in terms of doing guided growth. And we'd be looking at a guided growth procedure here to try and essentially shut down his anterior fascias, to try and reduce his slope, but at the same time correct his coronal plane. And, whether I do that with, guided growth is pretty straightforward, but from a point of view of actually planning and when to do it and then when to take the plate and screws out, I would use my pediatric colleagues and lean on them pretty heavily for that.
Okay. Franck, how do you manage those children with a ACL rupture, very young patient?
À ce stade, pour ce patient,
Yeah.
il a une rupture, donc
A new rupture,
il
2
est en
years after.
rupture, il a 11 ans.
He had a quad
Ouais.
used.
Alors, moi, je lui refais son croisé antérieur. Le tunnel tibial, il me semble bien, je le reprends. Le tunnel fémoral, il s'est fermé, pas de problème, je reprends la même technique. Par contre, il a un valgus par croissance boostée asymétrique. Et là, peut se discuter de lui mettre une petite plaque en 8 temporaire pour corriger ce valgus. Il n'est pas majeur. Pour l'instant, je le laisserai comme ça. On a encore largement le temps pendant toute la croissance de corriger son valgus. Donc pour l'instant, je le laisserai, mais je préviendrai les parents que plaque en 8, probablement avant la fin de la croissance, pour régler ce petit problème de valgus qu'on a à gérer.
Bertrand.
Plaque de croissance, bord médial du tibia. Hein, voilà.
I have a question for you, Frank. You don't have an extraarticular reconstruction? Okay. Which technique you will do?
I take a hamstring, put it on my bone block, and doing a...
Micro, Franck. Micro. What's up?
Oui. For this case, I would do an extra anterolateral reconstruction. Yes.
With hamstrings.
With hamstrings. Yes.
Okay.
The technique is to put it on my bone block inside the femoral tunnel and going to the tibia with a return.
So this is what this young boy had. He had a revision with a Macintosh pediatric technique and a medial meniscal repair because he had the new lesion of the medial meniscus. And he didn't show up for a lot of years, and he came back. It's just to show how is might be the evolution with those pediatric patients. He came back 2 years later. The valgus deformity increased a bit. He has 8 degrees of valgus, but he has valgus on the other side also. He has a boost on the femoral side, and the physis is still open. He's 14 years old. Les pediatric guys. Franck.
Speaking.
Je reviens en arrière.
C'est un grand mystère pour moi parce que la croissance accélérée, ça se produit dans les 18 mois qui suivent l'événement stimulant. Et ça, c'est bien connu par tous les pédiatres. Donc normalement, il n'y a plus de valgus qui doit s'aggraver au-delà de 18 mois de l'opération. Donc je vois pas pourquoi il aggrave son valgus. Alors à moins que, parce que toi, tu es passé à nouveau dans le tibia. Tu as fait un tunnel tibial.
I took exactly the same tunnels he had.
Ah oui, donc t'as pu faire ton petit boost toi aussi. Chacun le sien. Ouais.
Chacun le sien.
Can I say something? Maybe in my mind we should treat, the worst complication. Also, in this case, valgus is the worst one. So maybe I suppose to treat that one with epiphysiodesis and stop sports activity at all and wait for the late revision. This is
do you think
what I will do in a case like this, even at the first, so 3 years before this one, so at the second revision.
Do you think the lateral tenodesis could be involved in the deformity, the tenoepiphysiodesis effect?
No, I don't think so.
Bertrand, do you think it might exist?
No, but I'm not courageous, so I will send this patient to Frank.
Okay, so we tried to stop the overgrowth on the medial side of the femur, and the guy didn't show up for 2 years, and he came back, it was at the end of his growth, and you see the valgus deformity was well corrected, but it's quite a strange knee. He has 3 degrees of varus. I told him we should remove the plate, but he didn't show up. And then he came 2 more years later. He's now 19 years old. He has diffuse knee pain, big varus, 6 degrees, and a valgus deformity on the tibial side, and a varus deformity on the femoral side. Never seen this before.
But the good news that the ACL is still in place?
And
the ACL is still in place?
When I test it, it works, but I don't know if I'm good.
Al, what will you do there?
Well, question.
He's an adult man now, Hal.
Is he symptomatic? Does he have a problem with his knee?
Yeah, it's painful. He has diffuse pain on the knee. Let's say, it's his only complaint. He's totally stable.
Yeah.
He's a heavy worker, and he's painful in daily life.
You do what you've done. You've done a deformity analysis. You work out he's got a 2-level deformity on both distal femur, proximal tibia. So in this scenario, I probably would do a medial closing wedge, proximal tibial osteotomy. It's going to make his varus worse, but then do an opening wedge on his distal femur on the medial side. You can take the wedge out of the tibia and you can put it into the femur. And ultimately, you're looking for a neutral joint line with, neutral coronal plane with a neutral MPTA. If you get that, I think you'd be very happy.
Jean-Marie, est-ce qu'on peut te poser une question embarrassante?
Ouais.
Pourquoi tu as mis une plaque en 8 sur le fémur alors que tu as un valgus tibial?
Il y avait un valgus dans le fémur, mais j'avais pas bien analysé le valgus dans le tibia.
D'accord. Il y avait un valgus sur le fémur.
Ouais.
Donc, tu as eu un petit effet d'arrêt de croissance sur le fémur.
Ouais.
Le problème, c'est que le pont a lâché.
Le problème, c'est que
Le pont d'arrêt de
le gars il
croissance
était
a
aussi
lâché.
difficile à suivre, je crois.
Ça veut dire que ta croissance externe, elle a repris. Et tu avais la plaque en interne.
Exactement.
Et c'est pour ça que tu es parti comme ça. Et comme il était en valgus, bah du coup, le gamin, il s'est pas trop plaint. Parce qu'il a un varus fémoral et un valgus tibial. Il était pas trop mal. Il est pas revenu te voir.
Jusqu'au jour où il est revenu. So that's what I proposed. Exactly what you showed, Alan. I did a double level osteotomy. I did because it was too long on the femoral side, so I did a lateral closing wedge on the femur, but it was a big correction, 14 millimeters. It's huge, and a varus tibial osteotomy, a small one, and now we correct the global axis and also the segmentary axis. That's it, guys. Any comment? Do you still want to do pediatric cases? Surgery is the key. Merci beaucoup. I think we can close.